Hi, I'm Tom Burke, the Associate Dean for Public Health Practice here at the Johns Hopkins Bloomberg School of Public Health, and I want to welcome you to Public Health on the Inside, your inside look into the world of public health. So before we begin today, I want to ask you a question. Have you ever been in a really scary situation? And I have to tell you that I have. And those of us who travel internationally for public health have often been in situations that are really scary. My personal most scary moment has been driving at night on rural roads at high speed in India and dealing with truckers, cows, pedestrians, people on bicycles, and people in those rickshaws that you may have seen in movies, and they're romanticized, but they look scary. So today, I'm actually thrilled to introduce a colleague and friend, Dr. Adnan Haider, the director of the International Injury Research Unit here at Johns Hopkins, and a professor in the school's Department of International Health. He also directs the PhD program in health systems and is the associate director for global bioethics with the Johns Hopkins Berman Institute of Bioethics. He has more than 20 years of experience working on injury prevention worldwide and has been a global leader in international injury prevention, particularly traffic injury prevention. Adnan, welcome to Public Health on the Inside.
Thank you very much, Tom. Pleasure to be here.
Well, it's great to have you. And so first, I want to ask you, how did this all begin, your focus on injury prevention?
Well, Tom, that takes me back to my roots back home. I'm originally from Pakistan, and I grew up in the city of Karachi, went to medical school there. And my first real job after medical school was up in the northern parts of Pakistan, managing a primary healthcare project where the Karakoram Mountains that are between India, Pakistan, and China all converge. And as a young doc, most of the men who were brought to me in my primary healthcare center were from injuries. And I saw some of the most treacherous roads you've ever seen at elevations of anywhere from 5,000 to 15,000 feet, no guardrails, really old Jeeps at that time. This is, we are talking something like end of 80s, early 90s. And drivers were sticking to the road, and yet barely so.
And they just used their horns, not the brakes, those big, fancy-looking trucks.
That's correct. And you can imagine that these are all single-lane roads. And so if you have two Jeeps coming across each other, then there was a protocol of how one Jeep would wait while the other treacherously managed to bypass it. That's really when my interest in this burden of injuries started. And I became fascinated by the fact that we seemed to have a good understanding of how to prevent, diarrhea and pneumonia, even try and understand maternal mortality. But I couldn't fathom what to do about these injured, particularly young men, some of them very severely injured, whom I had to see, and in most cases, I really couldn't help.
Because I assume there's very difficult response times there, too. You're not seeing folks until quite some time after the injury occurs, given those roads.
Absolutely. And frankly, Tom, even if I saw them within seconds, I wouldn't be able to help them. The injuries would be so severe that it would take some of the best emergency medical systems in the world to possibly save them. And even if they are saved, the quality of life would be far from optimal.
Adnan, another issue in some of these rural communities is the issue of trauma care and response time. When an injury does happen, how much does it affect the outcome that we really don't have trauma care throughout the world?
Tom, that's a very important question. Actually, we are working right now on studying emergency medical systems and trauma care systems in low and middle income countries. The fact is that in most low income countries, we are finding that these systems are either non-existent, very embryonic, or in fact are very haphazard. So there is no central number people can call. There is no coordination mechanism to roll out ambulances. There is no trained technicians on board these ambulances, and there is no definitive care waiting for the patient at the end of the stream. So I'm working with colleagues like Dr. Kent Stevens, a trauma surgeon at Johns Hopkins Hospital, to look at countries like Kenya, like Cameroon, like South Africa, and begin to explore what are the determinants of this, what we call post-crash care. How can we ensure timely care and quality care? And those two elements indeed have been the challenge for countries like ours in the US. It's taken us many years to get to that perspective, and we are hoping now to help support and build capacity in these countries so that their trauma care systems also are responsive to the high burden of injuries and trauma.
Now, I want to ask you a question about injury prevention. Lots of people think traffic accidents, and we even call them accidents. But I think you have a different perspective on that. Tell me about the difference in perception and how we have to change that.
Actually, that's one of my most favorite topics to discuss. Because you're right, historically, in the English language, for example, the use of the word accident itself gives the connotation that these are uncontrollable, not preventable, neither predictable. And that's quite erroneous. Injury prevention science for the past 30, 35 years, and we have the pleasure at Johns Hopkins of having some superb colleagues who are really originating this science, such as Professor Sue Baker, have demonstrated that in fact injuries are not only preventable, but they're also predictable. So you can actually plan for reducing both the occurrence of injuries and certainly the impact of those injuries. And this is true for road injuries, as it is true for burns, as it is true for child injuries, and so on. And in fact, in communicating injury prevention lessons around the world, one of the things we've been fascinated about is the use of language. And in many languages around the world, you have only one word that can either be interpreted as injury or trauma or accident in the English language. So we don't have too many words to play with. And so it's been a lot of understanding the nuances, understanding how we can communicate these messages to populations that has used quite a bit of our energies and time.
So most people really don't have a grasp of the toll that injuries take worldwide. And you've done a lot of work on bringing science to this issue. 1.2 million people dying each year and 20 to 50 million injured. Can you talk a little bit about the work of the International Research Unit and the journal that you've put together on traffic injury prevention?
Well, Tom, when I first started nearly 20 years ago, very little was known about the basic epidemiology of injuries. Now, thanks to not only the work of our unit, but also many colleagues, including World Health Organization, World Bank, and colleagues working in other organizations, we understand that more than 5 million people die from all types of injuries on an annual basis. Of those, the largest chunk is from road traffic injuries, as you mentioned, at about 1.2, 1.3 million. But for us, what is most disturbing is that nearly 90% of these deaths are in low and middle income countries. In fact, the relationships are so skewed that some of the highest rates are found in sub-Saharan Africa and South Asia. And this is of great concern to us because, in fact, if you looked at things like road traffic, you would say, well, where are most of the cars? And you would say, well, in the high-income developed countries. But where are most of the deaths happening? And you say, wow, these are happening in low and middle income countries. Right. How does that make sense? Except if you think about who's dying on these roads. And eventually you figure out it's the pedestrians. It's those driving on buses. It's those who are on motorbikes. In other words, a person may not ever own a vehicle, but may die on the roads from a vehicle. And that's the tragedy that we are all trying to prevent.
In rural areas, people have to travel great distances and they don't have the resources. For instance, I've seen large families on a single motorbike with unprotected children just holding on at high speed. Tell me about some of the cultural challenges of raising awareness.
You know, one of the things that is most interesting is as we travel around, Tom, as you've mentioned, we go to different countries and cities and villages, and we see all sorts of things. For example, I've seen actually an animal-drawn vehicle which is carrying a car on top, inside which there is a motorbike. So I can't begin to describe to you the scenes that I've seen. What is very true is that in many instances, individuals don't have the capacity to choose. They must utilize whatever is in front of them because they're earning a livelihood. So when you begin to reason with an individual, for example, not to take 3 people on a motorbike, and yet you recognize that all of those 3 individuals, if they don't get on that motorbike, cannot earn a living and therefore cannot support their families, it's a very difficult situation. It's a complex situation, like in many other areas of public health. And so one of the things that we've started looking for is we can't change world economies in a day. We can't change cultures in a day. But what we can do is to make that ride safer. So what we are hoping to do then is to ensure that the individuals, including children, that are driving those motorbikes are, for example, wearing helmets. And we've had tremendous success in countries like Vietnam, where thanks to the generosity of colleagues that are doing research there, as well as donors like Mayor Bloomberg, we've been able to support helmet wearing for children. And that is now becoming part of national legislation. That means that police can enforce it, and there is availability of cheaper and safer helmets in countries like Cambodia and Vietnam.
That's fantastic. Tell me more about some of the other research that might be going on at your International Research Unit.
So, Tom, while we have very large, extensive projects going on in the field of road traffic injury prevention, at Johns Hopkins International Injury Research Unit, we are very fortunate to work with colleagues like yourselves in many different areas. A big cause of death for children between the ages of 1 and 4 in South Asian countries, particularly countries like Bangladesh, is drowning. And we've been approached by Bangladeshi colleagues to really explore that problem because, thanks to our colleagues in infectious diseases, over the past 10 years, many children are being saved from diarrhea, saved from pneumonia in that first year of life. But these same toddlers, the moment they start moving, they get near water bodies, they plop right into it, and they lose their lives. We do not want to lose the lives of these young children from drowning, having just saved them from diarrhea and pneumonia. So we are looking forward to doing a lot of work with organizations like the ICDDRB, or the International Center for Diarrheal Disease Research in Bangladesh, who have been decades of collaborations with Johns Hopkins, and explore how we can reduce the preventable mortality from drowning. Another area that we are working in are child injuries in homes. In fact, what we are finding that between the ages of 1 and 5, many of the injuries that occur to children are within their home environment. And one would say, well, surely homes must be safe. But actually, if you think about stairs, if you think about stoves, if you think about electrical outlets, if you think about poisons like detergents that are found in homes, actually there are tremendous risks inside homes, particularly, once again, urban slums. Think about rural areas, and think about kerosene and paraffin in Coke bottles. And how would a young child actually know that, in fact, these are substances that are not for them? So we are also working in countries like Pakistan in exploring that.
We have so many students, international and domestic, interested now in injury control. What advice do you have for our students who are looking toward perhaps a career or working in this field?
That's a great question, Tom, and obviously I want to support and encourage many younger colleagues to consider. I think there are two ways of thinking about this. First of all public health professionals should be sensitized to the burden of injuries and violence. You don't have to be an expert on it, but you've got to recognize that the spectrum of disorders that public health professionals deal with range all the way from infectious diseases to chronic conditions to injuries and violence. And I think that should be part of the training process, sensitization process for public health professionals. What we hope is that some of them will become more interested in this, and certainly picking up very important skills in the science of injury prevention is extremely important. Unfortunately, every day, even today, we come across colleagues who are well-meaning, who want to do good, but are not informed by the science of injury prevention, and so they might be actually wasting resources in interventions that haven't been shown to proven to be effective. And I'll give you a classic example of billboards across roads. Ministries of Education and Transport love investing in these billboards. Unfortunately, I haven't come across a single study that demonstrates that those billboards will reduce traffic injury rates. So, could that money be used effectively in other interventions, for example, is the question that we love to ask our colleagues. And I hope that the next generation of public health professionals will be better informed by science and bring rigor to injury prevention as well.
The importance of the evidence. Adnan, it's been absolutely a pleasure speaking with you today. I have one last question. Do you ride in rickshaws?
Actually, that's a great question, and I have to admit that I stopped riding in rickshaws simply out of fear for my own life and for the life of those working with me. So now we try and insist that we find cars that have seat belts so that we can ride in them. Once in a while, we will be in a situation where it'll be very difficult, but certainly no motorbikes, and certainly no motorbikes without helmets. That is absolutely disastrous. And last year, students from University of Michigan, and you may have heard just a week ago, 3 students from Boston University have died on the roads in other countries. Yeah. Our heart goes out to those families, but that's exactly what we want to prevent. We want our young people to be safe and excited by public health, but not lose their lives.
Adnan, thank you so much for sharing your knowledge and expertise and experience with us, and a special thanks to our listeners. Thank you for joining us today on Public Health on the Inside.